My name is Dr. Iman Musa. I am one of the students at the University of South Wales doing a postgraduate diploma in endocrinology. Today I'm going to talk about the thyroid fine needle aspiration, the technique and the indication. So slide number 1 is introduction. Fine needle aspiration is a minimal and non-invasive procedure. It is now considered one of the most accurate tests for the diagnosis of thyroid nodules. Usually it is done by an experienced radiologist, and it is an ultrasound guided biopsy in most of the cases, and involves the removal of cells from a suspicious area within the thyroid or within the body using a thin needle and a syringe. Then the sample of tissue or fluid is evaluated in the laboratory to determine the diagnosis. It is an outpatient procedure, and it is takes around 10 to 15 minutes. So what are the indications for the taking of a thyroid biopsy using a fine needle aspiration? Usually in a high risk history, after performing an ultrasound, if we have any suspicious on sonography or an ultrasound, we proceed for aspiration. So if we have a suspicious or without suspicious sonographic features of any nodule of more than 5 mm, it needs biopsy. Or if with having an abnormal cervical lymph node, we need definite biopsy of this lymph node. And in the presence of microcalcification on ultrasound, and the tumor is the nodule is more than 1 cm. So these are considered as high risk patients. If we are dealing with a solid nodule, if it is a hypoechoic and more than 1 cm on ultrasound, it needs a biopsy. Or if it is iso or hyperechoic but more than 1 to 1.5 cm. We usually follow the diagnostic criteria for fine needle aspiration cytology before we proceed for the test. So if we have a mixed cystic solid nodule with suspicious of sonographic features more than 1.5 to 2 cm, it needs a biopsy. Or if it is not suspicious but more than 2 cm, so any nodule, if it is not suspicious and it is more than 2 cm, it needs biopsy. For the spongiform nodules, more than 2 cm purely cystic, FNA is not indicated. So in summary of indication for thyroid biopsy, we usually follow any clinical thyroid nodule of more than 1 cm. If the nodule is cold nodule and hypofunctioning, and we deep in the history, so age of the patient and sex of the patient, any previous radiation, any family history of cancer, especially medullary thyroid cancer, it needs to be biopsied, and as well as the growth pattern of the nodule itself would help with the diagnosis of the thyroid nodule. So the technique is usually done. It is usually done under ultrasound guided, but in some centers it's done manually with only palpable thyroid nodule fine aspiration. But in majority of the centers, it is an ultrasound guided biopsy. So the patient is usually in a supine position, and the needles we use at 20 to 25 gauge needles, which is the most used for fine needle aspiration. We have another large needle biopsy, 16 to 18, is not usually used, and the core needle biopsy is 14 gauge needle. So all these are types of needle biopsy, but the most one is used for the thyroid is the 20 to 25 gauge needle. And it is conventional needle with a syringe, and the syringe is placed and the needle is placed on the syringe, and the needle is directed at the lesion, and once the needle is in the lesion, suction is gently applied. Multiple passes through the lesion are performed, vacuum removed, and the needle removed from the lesion. The sample is expelled on the cytology slide or into a carrier fixation solution or sent to the pathology laboratory in the needle itself. So the recommended thyroid fine needle aspiration technique is a maximum of 3 punctures, usually from two different sites, at least 2 different sites on the same nodule. Use a 25 gauge needle, and we don't do local anesthesia for this procedure. So all patients should have an ultrasound either before or after fine needle aspiration. So in the majority of case of fine needle aspiration, it is a benign into 95%, and only 5% are of neoplasm. So the most common neoplasm associated with biopsy of thyroid biopsy is the papillary thyroid carcinoma in 70 to 80% of the cases, followed by follicular thyroid carcinoma in 5% of the patients, and Hurter cell carcinoma in 5%. Also, medullary thyroid cancer account for 5 to 10%, anaplastic thyroid cancer for 3%, malignant lymphoma 1 to 2%, and metastatic carcinoma 2 to 4%. So, as we mentioned, 95% are benign lesions, benign thyroid nodules. Multinodular goiter is the commonest is the commonest form of benign thyroid nodules. Hashimoto's thyroiditis, simple or hemorrhagic cyst, follicular adenomas, and subacute thyroiditis. So, in case of a palpable solitary nodule, usually it is part of the multinodular, as we mentioned, multinodular goiter in 50% of the patient on ultrasound. The size of the other nodules is usually less than 1 cm in majority, but in 10 to 15% of the patient will have a second non-palpable nodules of more than 1 cm.